Okay, so I'll be giving the next presentation, broadly speaking, about causes, mechanisms, and models of tinnitus. So I'm going to start off with what Dennis McFadden edited a book in 1982. It was one of the first detailed, comprehensive reviews of the tinnitus and what people thought at that time. Perception of sound, it must be heard, it's involuntary, must not be produced intentionally, and originates in the head. It's not super hearing from something on the outside. I sometimes hear people say, well, tinnitus is just a symptom. That's okay. Hearing loss is a symptom. That doesn't mean that we can't understand it. It doesn't mean that we can't treat it. And I also don't like to use the word phantom perception, at least particularly around the patient, because for the patient, this is indeed a real sound. And for some patients, using the word phantom can have a negative impact on their original perception. Marlon did a wonderful review of the different physiological causes, particularly the middle ear causes. And what I tried to suggest many years ago is I don't like the terms objective versus subjective. I prefer to think of it as a middle ear tinnitus or a sensory neural tinnitus. And that's the same way that we talk about hearing loss. One of the reasons why we suggested that many years ago is because there are otoacoustic emissions that originate in the cochlea, spontaneous otoacoustic emissions, that can actually be perceived by an individual and also by somebody standing outside or listening through a sensitive microscope. So it's important because it's how we think about the etiology, how we think about treatments, whether it's a middle ear cause or a sensory neural cause. And most of the conference we're going to focus on sensory neural tinnitus, not middle ear tinnitus. The medical evaluation and treatment that Marlon referred to focuses on the middle ear tinnitus for the most part because that's something that he can do and can evaluate in some situations and provide a treatment. So sensory neural tinnitus could originate in the cochlea. It could have some vascular problem. It could be some mechanical problems. It could be sensory. It could be neural. It could also originate in the retrocochlear system, in one of the nerves, in the brainstem, in the central mechanism. So there's lots of different sources of this sensory neural tinnitus and some sort of interactions between the two. And when I started in this field, I was amazed that there was probably 300 theories of the origin of tinnitus in 1985, and there may be 3,000 now. And that's okay. It's useful, particularly if a theory can be tested, if it leads us in the right direction. But it's certainly clear that the entire auditory system in the brain is involved in a lot of these things. So I would argue that wherever it starts, whatever the initial cause is in tinnitus, and it could even be, we'll hear some information about the tactile system and how that somatosensory systems, it has to be perceived in the brain. So the brain has to be involved if a sound is perceived. It's also important to keep in mind sometimes the patients will come in talking about hallucinations. In fact, I recall giving a talk to audiologists many years ago, and some of the people, two people afterwards, said that they actually heard some music. And they had no other symptoms, no other psychiatric symptoms. And of course, we know from some of the work done by Penfield in Montreal in the 1960s and 70s that you could put an electrode in the temporal lobe of normal people without psychiatric symptoms, stimulating electrically these neurons in the temporal lobe produced perceptions of music and words and rhythms. And so it may very well be that in some people they have some activity that's originating in the temporal lobe in the complex situation which creates the perception of words or music. And so when someone says that, you shouldn't assume that they have a psychiatric condition, but obviously that's something that you need to consider and make sure that that is an issue, is or is not an issue. Often we will see patients who are referred from psychiatry because they're not sure what to do with the tinnitus patients. And also there are patients that we cannot help that we know that they need to see a psychiatrist or a clinical psychologist. So it can go both ways, and I'm not afraid to ask patients if they do have, if they are taking medications for depression or they are taking medications for anxiety. So keep that in mind as another cause of tinnitus in terms of hallucinations. So about a third of the patients have tinnitus in one ear. About half the patients hear their tinnitus in both ears. And about 10% of the patients will say it's somewhere in their head, or sometimes they can't originate it in any particular location. Very rarely does somebody say they hear their tinnitus out there in space. That happens very rarely. I've probably only seen 3 or 4 patients like that. So it's mostly the right ear or the left ear or somewhere in the head, different in different patients. And as Marlon pointed out, there's some diagnostic importance of a unilateral tinnitus. This is a review of different kinds of the percentage in the population with tinnitus, and as a function of the age, broken down by males and females. So the percentages, for those less than 30, it's less than 1% of the population. And as it goes up, it can be 10%. And this actually depends on the definition that is used in the surveys. So sometimes the prevalence is as high as 20%. Because we know that the most common cause of tinnitus is noise exposure, and for all of these percentages, we did a survey when I worked in England many years ago, and if no matter what the potential cause was, if you also had a history of noise exposure, your likelihood of having tinnitus in that category just about doubled. So I think that this decrease in the older age is an artifact because the sample size was less in that group. And sometimes I will say to patients that approximately 5% of the population has tinnitus at large. Probably as much as 20 or 30% has it over the age of 60. And of course, that age-related hearing loss, age-related tinnitus, more likely to have cumulative noise exposure, other disease processes. I also point out that they probably have some friends or people they know that actually have tinnitus. They just don't know that because it's invisible and they haven't talked about it with their fellow patients, with their fellow friends either. So this is a survey of people and looking at the different, whether they're using hearing aids or not. So this is an estimate from a large sample size, and so about 44% of the people that had tinnitus said they had normal hearing. These people, a little over half, said they had hearing loss, and most of them, however, did not use hearing aids at that time, even though they had tinnitus. So the interesting part of this is chances are all of these people actually had a hearing loss. But their tinnitus was the most important problem that they were experiencing. We all know how difficult it is for people to accept and use hearing aids, even though hearing is incredibly important to communication and interacting with people. But a lot of people don't deal with that appropriately. It turns out when they have tinnitus, a lot of people actually come into the clinic because of their tinnitus, not because of their hearing loss. They also have hearing loss, and they might also benefit from hearing aids, even though they're not prepared to even admit that they have a hearing loss. So one of the things that this is important in terms of setting up a clinic and offering tinnitus as tinnitus services to help your tinnitus patients is that it will also bring in patients who will need and benefit from hearing aids. So this is one reason why a lot of people, audiologists in private practice, get involved in tinnitus services, because it also increases the number of patients coming to them who they can provide hearing aids. Then they benefit both from their tinnitus counseling and sound therapy, and also benefit from getting high-quality hearing aids. So now we'll talk a little bit about the mechanisms involved, and I'm just going to go over this in a fairly simple fashion, because we're going to hear several interesting presentations on some new details about the potential causes of tinnitus and the brain mechanisms involved, and hopefully will lead us in some new directions. So spontaneous activity going on in the auditory system, the brain is there all the time. It begins, of course, at the junctions between the cochlear hair cells and the nerve fibers, but there's these neural junctions that lead all the way up to the brain and throughout the brain. And at these junctions, there are these neurotransmitters that go across the junctions, and tinnitus might easily be caused by some of the chemicals at these junctions are excitatory, and if there's an excess of those excitatory chemicals, then the nerve might become more active, and that might be perceived as a sound. We'll go into this in more detail. It's also clear that there are chemicals at these neural junctions that actually decrease the transmission of activity across the junctions. And it may very well be that some of these nerve fibers that are meant to monitor and regulate activity, if their function is decreased by these inhibitory chemicals, that also might create tinnitus. So it's quite complicated in the mechanism. Some of the chemicals that are excitatory in some parts of the auditory system are inhibitory in other parts of the auditory system. So we're going to hear more about that in quite an exciting way in a few presentations later on. Tinnitus clearly involves the brainstem and the cortex, and I recall early on, in the very first symposium on tinnitus that I'm aware of was a SIBA symposium. We had quite a bit of discussion. I was just beginning and intrigued by the discussions that were going on. In the 1950s, a lot of patients would come into a hospital with a unilateral tinnitus that they could not stand, and some of the surgeons would actually cut the nerve. Unfortunately, they still had their tinnitus in about 70% of the cases. They no longer had hearing in that ear, but they still had their tinnitus. So what that meant was that even though the person heard their tinnitus in one ear, it obviously was not a central phenomenon. In some of these first experiments we did in Nottingham, some masking experiments, people would hear tinnitus in one ear, and it turns out we could actually put some noise in that ear and make the tinnitus go away. And the person said, "Oh, that's great, I don't hear tinnitus in that ear anymore, but now I hear it in the other ear." So it was probably present in both ears at the same time, but if it's louder in one ear, it could be lateralized and you could only perceive it only on one side. The other interesting observation that we made was persons that had unilateral tinnitus in their left ear, we could actually put in a low-level noise in the opposite side, much lower than we had to worry about for some contralateral masking effect like we have to worry about in the audiology clinic. So they could hear tinnitus in their left ear. We put in a very low-level noise in their right ear, and their tinnitus went away. So this was a central masking effect, again, confirming that the tinnitus, even in these patients who heard it unilaterally, actually had some central mechanism that was critical. So we commented in several papers in the 1980s about how that even though people hear tinnitus in their ears often, that it quite commonly results in a tinnitus that must have some kind of central mechanisms involved, even though they hear it in one ear or the other. So we summarized several years ago the different models of tinnitus. As I said, there are probably hundreds and hundreds of detailed models. And these models, I would argue, are only useful if you can test them. It's easy for all of us to make up models, but if we can't test them, then it doesn't take us in any clear direction. So the way that I think about this is that tinnitus must be perceived in the temporal lobe, and we have different ways that the spontaneous activity might be affected. And so the first way is simply an increase in spontaneous activity somewhere in the auditory system. They're getting up to the temporal lobe. And of course, when there's a spontaneous activity going on all the time, when we hear a word, the activity on that nerve becomes very active and synchronous in different regions, depending upon the frequency content and the timing. And it may very well be that there's simply, for some reason, an increase in spontaneous activity somewhere in the auditory system. And that increase in activity is perceived as a sound. And we noted because there is inhibitory activity in the system, it may be that there's a decrease in activity in some regions, a decrease in the inhibitory activity. And as was pointed out by Nelson King many years ago, it also could be an edge effect. So if there's a lack of activity in some region, the normal suppression that goes along throughout the auditory system, there's no suppression because there's a loss of hair cells, for example, or a loss of nerve fibers in a particular frequency region that inhibits the suppression and creates more activity than is supposed to be there at the edge where there's no suppression mechanism. The second general area that tinnitus could be caused by in terms of a physiological model is we refer to as cross-fiber correlation. So there's normally, at least in the auditory nerve, there's the activity on different nerve fibers are completely independent. And Egermont and Aggie-Moeller commented many years ago that it may be that either in the auditory nerve, and I'll show some pictures of this, or upstream, that the nerve fibers might interact, even in the brain for that matter. And that cross-fiber correlation might create some signal to the brain that the brain might say, oh, there's something going on, there must be a sound out there. The third category is more fibers with similar best frequency following the hearing loss. So the analogy that I use here is if you have a hearing loss at 4,000 hertz, you've lost some hair cells in the cochlea, and within weeks after that, you start to lose nerve fibers that go up to the brain at 4,000 hertz. The part of the brain that normally responds to 4,000 hertz is still active, but it's now not getting any information, so the part of the brain sort of starts to look around and it starts to respond to the 3,000 hertz region. So now you have two parts of the brain that are responding at 3,000 hertz, and so maybe you start to hear that extra spontaneous activity and hear a 3,000 hertz tinnitus. So these are just simple analogies of what goes on, what might go on, and we're going to hear more detail and I'm sure some unique strategies as well. It's also important to keep separate the perception of the tinnitus from the reactions to the tinnitus. So the reactions to the tinnitus involve all kinds of the brain. So the most common parts that were identified early on is the amygdala, the autonomic nervous system. If you become afraid of, you're going to hear these sounds. And this is, I would say in some ways, this is normal. So it doesn't surprise me that lots of regions of the brain are active when you have tinnitus. That is, if somebody steps on your toe and you're really angry because they stepped on your toe, then lots of areas of your brain become active. And if you're upset about your tinnitus, lots of areas of your brain are active in the same way. So it's important to keep in mind that you have your tinnitus and you have your reactions to the tinnitus, and there indeed will be different parts of the brain that are going to be active in different ways, depending upon what the causes are. There might also be some interesting, and we've heard there's several theories about how other parts of the brain contribute to the tinnitus, but at least as a first pass, I would argue it's important to keep the distinction between the tinnitus itself, that activity in the brain that's causing the tinnitus, and that activity in the brain that is related to the secondary or the reactions that you have as a result of having that extra activity going on. So this is the hearing nerve, and this is an example of spontaneous activity that goes on here. And these are some pictures from our tinnitus activities treatment that you're going to hear later on today and tomorrow from Shelley. So in the normal hearing nerve, there's activity going on, and normally you would not hear that. So there's spontaneous activity, we don't hear it, no big deal. When we say the word table, lots of nerve fibers become active, and on any one of these active nerve fibers, there's some activity related to that word table. And by monitoring all these 40,000 nerve fibers and integrating them with your brain and the memories in your brain, you understand that spontaneous activity means that somebody said the word table. Well, it may very well be that if tinnitus is related to an increase in spontaneous activity, for some reason there's lots of activity on some of these nerve fibers, and your brain looks at this activity and it says, oh, I hear a sound. And sometimes what I tell patients when I'm showing them slides like this is that your brain's doing what it's supposed to do. It's interpreting that extra activity as a sound. This is the cross-correlation of the fibers example. So here's 3 fibers, and say they're not correlated very well. This is an extreme example of the 3 nerve fibers that are all firing at the very same rate. That doesn't happen if you don't have, if the theory is that that normally doesn't happen, but maybe if all this activity is synchronized, the brain says, hey, there's something going on there, and this is spontaneous activity, and so that the brain interprets that as a sound. So normally, of course, we have these nerve fibers going up throughout the auditory system, and they're covered with this myelin sheath. It's sort of like an electrical wire with a rubber coating on it, so the electricity doesn't pass from one wire to the other. And what happens with this myelin sheath is it may very well be that there's a damage to the myelin, and therefore what happens is as this electrical impulse travels along this wire, this nerve, that the electrical activity is then spreads out and perhaps activates other adjacent nerve fibers and therefore fires synchronously or in some systematic way. So that's the second option. The auditory brain reorganization, which is quite often used these days, again, the corresponding parts of your brain are missing out in that 4,000 hertz region. And after several months, those neurons start to respond to adjacent frequency regions, and you have an overrepresentation. There's a few different takes on this, and I think we'll probably hear some more about that later. The analogy that Dick Salvi gave to this was this loss of a finger. So if you have a finger that's lost, the part of your brain that's up there that was responsible for the tactile sensations of that finger eventually starts to respond to adjacent areas. And so in some ways you start to think that you have that finger present, and they refer to this as the phantom sensation, and this analogy has been used for tinnitus as well. So for the mechanisms involved, there has to be several different mechanisms involved. We talk about tinnitus as if it's only one thing, but as we'll see in lots of the talks today, that tinnitus has different causes, different treatments, even with the sensory neural tinnitus, and there's likely many different mechanisms involved in different people. We argue that the auditory cortex has to be involved if you're hearing things. There are at least 3 possible mechanisms, and probably many more. If you have an emotional response to your tinnitus, then other parts of the brain, including the amygdala, have to be involved as well. And there may very well be some other neural systems that have an impact on your tinnitus or your reactions to your tinnitus as well.